Greetings to all participants. The lecture that we will be seeing in the next 20 minutes or so would be into the perioperative treatment in muscle invasive bladder cancer, neoadjuvant and adjuvant approaches. The following are my disclosures. These are the learning objectives. At the end of this lecture, we hope to understand the principles of neoadjuvant chemotherapy, to understand the principles of adjuvant chemotherapy, and to understand the role of immunotherapy in management of muscle invasive bladder cancer. As an introduction, it is vital to understand that the current gold standard management of muscle invasive bladder cancer is radical cystectomy with pelvic lymph node dissection. This would be regarded as the definitive curative treatment in muscle invasive bladder cancer. Sadly, though, with best available evidences, 50% of these patients will eventually experience relapse, either locally or more commonly distally. There is a need to consolidate outcomes with perioperative therapy. So if you would look into the small diagram below the slide, you would see that radical cystectomy occupies the center, which is the definitive treatment. And neoadjuvant therapy would be the treatment that precedes radical cystectomy. Adjuvant treatment is the treatment that would be followed by the radical cystectomy. And perioperative treatment would combine both neoadjuvant and adjuvant treatment, sandwiching between radical cystectomy. So let's now look into the role of neoadjuvant chemotherapy. So this is a meta-analysis that looked into the role of neoadjuvant chemotherapy in the management of muscle invasive bladder cancer compared to no neoadjuvant chemotherapy. So if you would look into the second half of this particular meta-analysis forest plot, we would then see that platinum-based combination actually results in an improved overall survival, with a hazard ratio resulting in 13% improvement of survival, which is statistically significant. So this establishes the role of neoadjuvant chemotherapy in the management of muscle invasive bladder cancer. In terms of the choice of chemotherapy, this meta-analysis looked into the difference between gemcitabine cisplatin, which is GC, versus MVAC, combination of methotrexate, vinblastine, doxorubicin, and cisplatin. And based on this particular forest plot, it is evident that although there is a trend towards favoring MVAC, the difference is actually not statistically significant, suggesting that between GC and MVAC, the outcomes are likely to be similar in the neoadjuvant space. However, when GC is compared to dose-dense MVAC, then there is a significant difference in terms of overall survival and pathological complete response rates. However, the use of dose-dense MVAC is associated with an increase in toxicity. This is the VESPER trial, which is a phase 3 randomized controlled trial looking into the subpopulation of patients of 500 randomized to receive 4 cycles of GC or 6 cycles of dose-dense MVAC before undergoing radical cystectomy. So as we would see, the risk of nausea and vomiting is significantly higher with dose-dense MVAC. The risk of asthenia is a lot higher with dose-dense MVAC. And in terms of hematological toxicity, anemia stands out as more prominent with the use of dose-dense MVAC. Although the other parameters do show a numerical increase in toxicity with the use of dose-dense MVAC, those differences were not statistically significant. So bear in mind that the use of dose-dense MVAC, although results in an improved overall survival, it does come at an expense of increased toxicity. So, in terms of response rates, looking into the various combinations of neoadjuvant chemotherapy, we could see that the PCR rates, regardless of the use of MVAC, DDMVAC, AAMVAC, or CG, results in an average PCR rate ranging from 25 to 42%, suggesting the importance of neoadjuvant chemotherapy in downsizing locally advanced bladder cancers. Downsizing into non-MIBC, which is less than PT2, is also significantly observed in about 40 to 60% of patients, and with a very significant improvement in the median or 5-year overall survival rates. So now let's look into the role of neoadjuvant immunotherapy. So we have got an array of immunotherapy to be used in the management of bladder cancer. Of course, we have got the classical checkpoint inhibitors targeting PD-L1, which is pembrolizumab, nivolumab. And we have got the antibodies targeting CTLA-4, such as ipilimumab and tremelimumab. So we have targets to PD-L1, such as atezolizumab and durvalumab, as well as we have got ADCs targeting TROP2 and Nectin-4, such as enfortumab vedotin and sacituzumab govitecan. So let's first of all look into the data available for neoadjuvant immuno-oncology monotherapy. So this is a non-exhaustive list of trials that looked into phase 2 studies of single-agent immunotherapy in the management of bladder cancers in the neoadjuvant setting. So as you would see, the PCR rates are fairly decent, probably with the exception of the nivolumab ipilimumab trial. The rest of the trials do show a significant improvement in PCR rates, ranging from 20 to 50%. And that is highly encouraging. And some of these trials do report a very encouraging relapse-free survival and overall survival data. And therefore, single agent immunotherapy has become an option of treatment in the management of cisplatin ineligible population. So cisplatin ineligibility is characterized by ECOG performance status of 2 or worse, glomerular filtration rate of less than 60 ml per minute, audiometric loss exceeding grade 2, significant peripheral neuropathy, and cardiac failure with a NYHA class 2 or worse. The current recommendation for patients who are cisplatin ineligible will be to undergo upfront radical cystectomy. And this is mainly because the role of carboplatin has been rather questionable because of inferior response rates and survival rates compared to cisplatin. And that has also been cited to be due to a lower carboplatin equivalent dose as compared to cisplatin. And as you can see in the diagram shown about here, if the patient has got a very good creatinine clearance of exceeding 60 ml per minute, cisplatin-based chemotherapy is the choice. If they are cisplatin ineligible, then radical cystectomy or an approach with a non-cisplatin-based combination may be recommended. And when we do have an overlap between 40 to 60 mils per minute in terms of renal function, then patients may be treated in either setting based on expert opinion. There is no direct evidence to guide our treatment decision at this point in time. So let's now look into the combination of neoadjuvant chemotherapy with immunotherapy. This is a non-exhaustive list of looking into phase 1B and phase 2 trials of cisplatin-based chemotherapy combination with immunotherapy. So again, if we would like to look at the PCR rate column, it is very, very encouraging with an improvement in the PCR rates as compared to neoadjuvant chemotherapy alone, with a range of percentage from 45% up to 65%. And some of these studies have also reported a fairly encouraging survival rates and relapse-free survival rates. So Niagara is probably the most recently available evidence to guide us with regards to the use of immunotherapy in the neoadjuvant setting. So Niagara was a randomized controlled trial looking into the combination of durvalumab with gemcitabine cisplatin versus gemcitabine cisplatin in the neoadjuvant space, followed by radical cystectomy. And patients who received durvalumab in the neoadjuvant setting went on to receive adjuvant durvalumab as well. Looking into the primary endpoint of event-free survival, this was a positive trial with a hazard ratio of 0.68, and this was statistically significant. The overall survival rate, although yet to be mature, already shows an improvement with a hazard ratio of 0.75 and statistically significant. The PCR rates are also very encouraging, with a PCR rate in the combination arm at 37% versus 27%. So Niagara is the current standard of care for patients with neoadjuvant approach for muscle invasive bladder cancer based on this trial. But this may not be very true, as many of the other trials are also closing up on their accrual, and we will have more options of immunochemotherapy option combination in this space. So let's now look very briefly into the role of adjuvant therapy in muscle invasive bladder cancer. The indication for adjuvant chemotherapy would typically be T3 to T4 pathological state, pathological node positive disease, as well as non-metastatic disease. It has also been used, but uncommonly, for patients with earlier stage bladder cancer with a more aggressive grade of urothelial carcinoma. Some of these patients may have received neoadjuvant chemotherapy, and the commonest regime used in the adjuvant space will be MVAC and GC. So this forest plot actually shows an outcome of a meta-analysis that looked into a combination of trials on adjuvant chemotherapy, which is cisplatin-based. And the reason to show the forest plot is to highlight as to how heterogeneous these studies are, to result in the combination hazard ratio that is statistically significant at 18% reduction in the risk of mortality. And with that, we now also have adequate amount of evidence on the use of adjuvant immunotherapy in the management of muscle invasive bladder cancer, mainly guided by these three trials: the Ambassador, Checkmate 274, and IMvigor 010. So let's look at IMvigor. IMvigor was a trial using atezolizumab in the adjuvant setting, and this was essentially a negative trial. And this was the first IO study to be published in this space. And the negativity discovered in this particular study was rather concerning on the role of immunotherapy in adjuvant management of bladder cancer. However, we then had the evidence from Checkmate 274 on the use of adjuvant nivolumab versus placebo. Now, this was a positive trial with an improved disease-free survival rate of 25.6 months versus 8.5 months, as well as an improvement in the overall survival in the ITT population, 69.5 months versus 50.1 months, as well as an improvement in overall survival in the PDL1 enriched population of more than 1%, which was not achieved in both arms, but at 3 years was reported to be 71% versus 56%. So this is a positive trial suggesting the importance of addition of nivolumab in the adjuvant setting. And we also have the results from the Ambassador trial looking into adjuvant pembrolizumab. Now, this study was mainly powered to look into disease-free survival, which is actually positive. However, the overall survival data has yet to mature and is currently still negative. So these sequential trials that were then published and made available further consolidated the evidence for the use of adjuvant immunotherapy following radical cystectomy, which then guides the current ongoing trials in the field of perioperative chemotherapy in combination with immunotherapy. So in the cisplatin eligible space, we have Keynote 866, Energize, Swap Gap, and so on. And in the cisplatin ineligible space, we have NeoCombo, EV303, Volga, and so on, so forth. Some of these trials also utilize ADCs, both in the cisplatin eligible and cisplatin ineligible space. We also have an ongoing trial in the neoadjuvant space for FGFR mutation positive, which is SOGUC NeoWIN trial, looking into the combination of erdafitinib and sertrelimab. So we are keenly awaiting the outcome of these trials, which will quickly change the landscape of management in the perioperative testing of muscle-invasive bladder cancer. So this is an example of the trial Energize, which looks into the combination of gemcitabine with nivolumab, as well as an IDO1 inhibitor, which lindodrostat. So this study is currently ongoing, and this incorporates both the neoadjuvant component as well as the adjuvant component before and after radical cystectomy, respectively. And these are the format of trials that we will be seeing in the upcoming publications. So in summary, cisplatin-based neoadjuvant chemotherapy improves survival in MIBC, and PCR rates and survival rates are improved with the addition of immunotherapy. Cisplatin ineligible patients are also now able to benefit from neoadjuvant therapy with immunotherapy monotherapy. Cisplatin-based adjuvant chemotherapy improves outcome in muscle-invasive bladder cancer with high-risk features. However, the level of evidence is weaker as compared to neoadjuvant chemotherapy, and tolerability post-radical cystectomy is usually of concern. Mixed results with the use of immunotherapy trials have not stopped the efforts of the current ongoing studies on perioperative approach in MIBC, looking into the combination of neoadjuvant chemotherapy with immunotherapy, followed by adjuvant immunotherapy. With that, I thank you all for your kind attention.